Members of the jury, good morning. Mr. Haynes, please call your next witness.
Defense calls Jeffrey David Lewine.
Members of the jury, this witness has been sworn.
What's your name, sir?
Jeffrey David Lewine.
And we should say Dr. Lewine, is that correct?
That is correct, sir.
All right. How are you employed, Dr. Lewine?
So I am a professor of translational neuroscience at the Mind Research Network in Albuquerque, New Mexico. I also have academic appointments in the departments of psychology and neurology at the University of New Mexico. I'm the CEO and CSO of a small business known as the Center for Advanced Diagnostics, Evaluation and Technologies. This is an organization that's developing new therapies for autism and traumatic brain injury. And I'm also the director of research for Beyond Barrier Therapeutics, a small pharmaceutical company that's developing a therapy for TBI.
So, what's your connection to this case?
So one of my areas of expertise is brain imaging, especially in relationship to things like traumatic brain injury, substance abuse, and autism spectrum disorders. And as you heard yesterday from Dr. McGarrahan, based on her neuropsychological testing, she had concerns about possible brain injury for Mr. Cahill. So on her recommendation, Mr. Cahill's legal team decided to go and pursue advanced imaging, something known as magnetic resonance imaging. And I was involved in the neuroscientific evaluation of those data from both a qualitative and quantitative perspective.
All right, so since we are not your students at the university, explain what we mean when we talk about neuroscience.
Sure. So neuroscience is basically the study of the brain and nervous system in health and disease. And it includes everything from looking at individual brain cells and the supporting cells, the molecular biology of the brain, but then also how brain cells connect together to form networks that support various cognitive, motor, and sensory functions. And it also includes evaluation of how brain dysfunction can lead to cognitive or psychiatric compromise.
All right. And so, in order to work on this case, what material did you look at?
So primarily, I looked at the actual magnetic resonance imaging data, and I'll explain all that in a little bit. But MRI basically takes a picture of the brain and allows us.
I mean, the brain's inside your bony cranium. So how can you look inside there?
So in the brain, there's water, and water has hydrogen protons. And our physicist friends have developed techniques whereby using magnetic fields coupled to radio frequency pulses, you can actually look at the behavior of the hydrogen protons, and from that construct an image of what the brain looks like.
So as if you were X-raying the brain without shooting the harmful radiation into it.
It's similar to X-rays. There's some differences, but the end result is you get a picture of the fine structure of the brain.
Which before you couldn't get except by examining it after a person had died.
Yeah, certainly originally autopsy was the only available method. Something known as computed tomography became available. Magnetic resonance imaging has really changed the landscape in terms of our ability to look at the fine details of the brain.
And when we look at the structures inside the brain, that can inform us about what may be going on with the brain. Is that correct?
Yes. So there's you can have gross structural damage. We can also look at the size of various areas of the brain. We can look at the integrity of the interconnections within the brain. And all of that provides us information on the structure of the brain, which has implications for brain function.
Right. And so in Mr. Cahill's case, Did you look at any records or documents that were provided to you?
Yeah, so we kind of asked the question in two phases. The first phase, is there anything wrong? That is a relatively straightforward yes or no question, again, based on the visual inspection, based on the quantification. The second question of interest is, if there are things wrong, why are they wrong? And in order to understand that, you have to have a detailed, or as detailed as possible, understanding of the individual's history. And so I did analyze numerous medical records, school records, other records on Mr. Cahill to try and help provide some insights into the causes of the abnormalities that we saw.
All right. And did you also look at Dr. McGarahan's testing and results that she obtained in her interviews with him?
Yes, so I had Dr. McGarahan's scores on the testing. I also had a report from Dr. Clem, the state neuropsychologist, who did very similar testing. And so one of the things I was looking for is what's known as convergent validity. Are the areas that are showing compromise on the scan, does that make sense in terms of the functions that are compromised for the individual?
And have you prepared a PowerPoint presentation that will assist the jury in understanding this material?
Yeah, so I have a relative, hopefully brief PowerPoint to just give some background on the brain and then talk about some of the specific findings.
Are you able to show that for us now?
Yes, sir.
Please do. Just a minute.
And Your Honor, is it okay if I stand so I can point to things? Thank you. It worked when we tested it, and now it's not. There we go. So again, what I was asked to do was review the magnetic resonance imaging data. And this was done from both a perspective of visual inspection and quantification. The visual inspection was done in conjunction with Dr. Travis Snyder, who's a board-certified neuroradiologist. Again, the data underwent what are known as quantitative analyses, where we actually look at the size of various brain structures and compare that to a normative database, similar to what Dr. McGarahan does in her testing. She gets scores on various tests, and then she compares that to a database to determine whether those scores are abnormal.
All right, so let me stop you for a minute and ask this question. So the analyses were quantitative volumetric analyses and qualitative analysis. So volumetric, that tells me we're measuring the volume of something, like here's a bottle of water, its volume is 16.9 fluid ounces. Yeah,
so we actually have computer programs that divide the brain into various functional areas. In this particular case, we look at 107 different brain areas to look at the size of those areas. We also look at the white matter pathways. We look at
what's white matter?
So white matter has the axons, the interconnections between brain areas. And so we also look at the integrity of the white matter.
So an axon is a nerve that connects parts of the brain. Is that correct?
It's the fiber part of the nerve cell that connects parts of the brain. I'll explain all that in a moment.
I mean, if we're thinking of an analogy to a radio, it's like a wire that connects parts of the brain.
Yeah, so here are what brain cells look like. And they have a cell body, which is kind of the command center of the brain. They have the dendrites, where the information comes in. And then they have the axon, which allows one brain cell to talk to another. And so the axons, in general, travel in what's known as the white matter of the brain. So we can selectively look at the white matter versus the gray matter, which is where the cell bodies are. And the brain is like a communication system. It's kind of like the talking head. So there's processing units, and those have to talk to other processing units in order to relay the information. So if you damage the processing unit or you damage the interconnections between units, that's going to disrupt brain function.
All right. So tell me what you looked at with regard to imaging concerning Mr. Cahill.
Right. So just one last point before I do that.
Sure.
The brain is organized into different areas, so different parts of the brain are involved in different brain functions. And again, if a brain cell in this part of the brain wants to talk to a brain cell in this part of the brain, it sends its axonal fiber through the white matter. And different parts of the brain are specialized for different things. So, for example, the frontal lobes are mostly involved in what are known as executive functions, decision-making, regulation of behavior. The occipital lobes in the back of the brain mostly process visual information. And again, if you destroy either the modules or the connections between modules, you'll get disruption of function. And so there's many different things that can influence how the brain develops. Genetics has an influence. The environment has an influence, and that can be good. So good school education makes nice, good brain connections, but neglect and abuse actually disrupt brain connectivity.
How about toxic substances? Could they disrupt that?
Yeah, so toxic exposure, so substance use, alcohol abuse, drug abuse, exposure to toxins can all disrupt brain development. Injury can disrupt brain development, so things like traumatic brain injury, and psychiatric diseases are also associated with disruption of brain development. So brain's very, very complicated, and how you respond to your environment is a reflection of how your brain has developed and been influenced by all of these factors. And so what we're able to do, again, with magnetic resonance imaging, is through the use of magnetic fields and radio frequencies, we can get pictures of the anatomy of the brain. By pulsing the radio waves a little bit differently, we can selectively look at the white matter interconnections of the brain. And so what we're going to do is we're going to look at these pictures for things that are abnormal. This last point is going to come up in the next slide. Just to be annoying, radiologists look at the images from the foot up. So the right side of the brain is on the left, and the left side of the brain is on the right.
And those images of brains along the bottom of that slide, those are for illustrative purposes, right?
That is correct. These are not Mr. Cahill. Somehow the clicker has decided to go to Never Never Land. Is it possible to advance to the next slide? Technical difficulties. There we go. So again, both Dr. Snyder and I initially did independent visual inspections. I do things from a neurobiological perspective. I'm a neuroscientist. I'm not a medical doctor. Dr. Snyder does it from a neuroradiological perspective. We then compare our notes and see if we agree and disagree. And there are several things that we were able to see just on visual inspection. So this is a slice down the center like this. Again, right side of the brain, left side of the brain. This is a part of the brain known as the medulla by the brainstem. And what you can see here is instead of this being nice and straight, it is shifted over towards the left side. So this is what's known as a mass effect. There's something causing this. And according to Dr. Snyder, this relates to something known as acacia of the right vertebral artery. And it's causing distortion of the medulla.
So what is that acacia
of
the artery?
Acacia of the artery is basically swelling of the artery. It is most likely, according to Dr. Snyder, a reflection of Mr. Cahill's hypertension. These can be benign. They can sometimes cause symptoms. We don't have enough information in this case to know whether this is specifically causes symptoms. But it's a visual finding that we can see here.
So this is why your doctor tells you high blood pressure is bad for you, lose weight and don't eat so many French fries.
It's one of the reasons.
All right. And so, all right, so what's the next thing you were able to observe?
Another thing that we noticed, again, on the right side, is that there's an abnormal mass here. You can see there's not something equivalent on the left. There's an abnormal mass here. Based on its location and configuration, Dr. Snyder believes that this is most likely something known as an acoustic neuroma. It's a type of brain tumor, fortunately not a cancerous brain tumor, it's not been spread. But it's a brain tumor that can lead, in particular, to compromise of hearing. And
so acoustic, that means having to do with sound, right? And you nodded your head, but answer yes or no.
Yes, sir.
All right. And then a neuroma, that is literally, it's a new growth. It's a structure within the skull that is not part of the normal anatomy.
Yeah, so the eighth cranial nerve is the auditory nerve. It is covered by something known as a myelin sheath, and the Schwann cells that produce the myelin become abnormal and give rise to this neuroma.
And how and in what way would that affect hearing?
So basically, what happens from a neurobiological perspective is this abnormally compresses the auditory nerve, so you get disruption of hearing, in this case, from the right ear.
And that is that something that could be helped by the hearing aids they advertise on old people's TV, or no?
Hearing aids can help a little bit. Usually what's done, and I'm not a medical doctor, what the literature says, is sometimes these are benign and you don't need to do anything to them. There are potential surgical options, radiotherapy options. Those would have to be decided by a medical doctor taking a look at the images and the actual hearing function.
Does it, over time, would you expect that acoustic neuroma to grow or to remain the same size?
In general, acoustic neuromas grow, but at a very slow rate. So often the recommendation is just to track things along with symptoms to see if intervention is needed. But again, that's a determination to be made by a physician, not myself.
And as they grow over time, what effects would we be expecting maybe to see?
Again, just increased compromise of auditory processing.
All right. So what's the next thing you were able to observe in looking at these images?
So Mr. Cahill also has something known as a left temporal lobe arachnoid cyst. So this is how it's like down the midline, the high frontal lobe, occipital lobe, temporal lobe here. And there's a large fluid-filled cavity at the anterior margin of the left temporal lobe. These are usually developmental in origin. They're usually benign, although they have been associated with an increased risk for epilepsy.
All right. So when we say developmental in origin, what do we mean by that?
So it's been there since birth. And so, again, they're sometimes associated with increased epileptic activity. We do not have any evaluation of epileptic activity from Mr. Cahill. We do not know if this is benign or potentially positive.
All right. Anything else that you located in your review of these images?
Yes. So on these particular types of images, this is known as an axial or transverse image taken this way. So front of the brain, back of the brain, right and left hemisphere. And so the white matter on this particular pulse sequence actually looks gray. This is the white matter all in here. The cortex of the brain, which is where the cell bodies are, along the outside. But what you see from Mr. Cahill is he has a number of these very white matter connections. They have many possible origins. You sometimes get white matter hypertensives with normal aging. They can be caused by hypertension. They can be caused by traumatic brain injury. They can be caused by many other things. It is often extremely difficult, based on the imaging alone, to know what the etiology is, what the cause is. And again, you need to go back then and look at supplying history to try and see what makes most sense based on where the lesions are located. White matter hyperintensities that are associated with hypertension, for example, tend to be very deep within the white matter. White matter hyperintensities that are associated with things like traumatic brain injury tend to be more superficial, close to the gray white matter junction, but those rules are not absolute.
Can you give the doctor your lapel mic, and also a reminder for you to please speak into the microphone?
So when the little green light is on, it's going. It has a strong battery because there's all 4 bars. And I think if you talk like this.
Is that better? Can you all hear me now? Great, thank you. Thank you.
It's more for the folks on YouTube who may be watching.
So there's one last set of findings on visual inspection that we see. There's a special imaging sequence that we can do, something known as susceptibility weighting imaging. It is very sensitive to iron. When there are bleeds in the brain, so little tiny strokes, that leaves behind blood products that we can then image. And so what we see are these dark circles here at numerous places within his brain. That is abnormal. That is believed to be a sign of microhemorrhages for Mr. Cahill. And most likely origin of those microhemorrhages is his hypertension. So we have a collection.
So let me ask a couple questions about that. A hemorrhage inside the brain, a lot of lay people would describe that as a stroke, right?
So it's technically a stroke. It's a very, very, very small stroke. So the types of strokes that you wind up going to the hospital for usually involve very large territories, so major arteries get clogged or ruptured. These are what are typically referred to as microhemorrhages. And you can get microhemorrhages in traumatic brain injury as well, but the profile and distribution in this case really looks more like hypertension as the cause.
So some doctors might talk to people about a mini stroke. Is this what we're talking about here, or no?
It's even less than that. So mini strokes are usually what are known as transient ischemic attacks. Those still involve large territories for the brain, have clear functional consequences. Depending on the specific locations of the microhemorrhages, they may or may not have major functional consequences.
So a person could suffer a micro brain hemorrhage and not be conscious that that had happened.
That is correct.
But would a micro brain hemorrhage damage the structure of the brain and produce effects over time?
It's unclear, so the number and size matters. These happen to be very small. He actually has a lot of them. So there may be some functional consequences. They are scattered throughout the brain, so it's not like you can have a stroke which affects movement on one side of your body or affects language. Those are large strokes. These are much, much smaller than that, much more difficult to relate these to specific functional deficits.
Do they have a cumulative effect so that if you have 1 or 2, it's not likely to be a problem, but if you have 20 or 30, more likely that will be a problem?
Yes. So certainly the more tissue that gets damaged, there's going to be increasing functional complement.
So how many in total did you see in the images you looked at?
So I believe for Mr. Cahill, we had 10 microhemorrhages.
All right, so compared to others you have observed, is that not so many, about a medium amount, a large amount? What can you give us any feel about that?
It's a medium to high amount, but again, they're small and they're scattered, so specific functional consequences for the microhemorrhages are not clear.
Well, I mean, I get it that we can't say, aha, these microhemorrhages caused this, but the fact that they're present, the fact that there are 10 of them, that's significant to you as a neuroscientist when you see all this data. Yeah,
I mean, clearly having microhemorrhages is a bad thing. The fact that he's already had microhemorrhages would raise, significant concerns about his hypertension, and this overall profile says there's a real need to get the hypertension under control.
All right. So what else, if anything else, did you find in examining these images?
So these were the findings that we had just by looking at the brain, looking at the images. As I mentioned, we also do what are known as quantitative analysis.
And what does that mean?
So most types of brain dysfunction and structural compromise, even with magnetic resonance, you can't see by just looking at them. So what we need to do is actually go ahead and measure things. So in conditions like autism spectrum disorder, in conditions like schizophrenia, in conditions like substance abuse, it's often the case that visual inspection looks fairly normal. And it's not until we start measuring the size of brain areas or the integrity of the white matter connections that we can really identify what the abnormalities are. And I'll use autism spectrum disorders as an example because I work with a lot of kids with autism. And I have kids who have no language, no eye contact, horrible seizures, sit and rock back and forth all the time, clearly aberrant brain function. When you do a gross structural evaluation of the brain, it's completely within normal limits. It's not until you start to do these advanced types of imaging and do quantification that you can start to identify, oh, here are problems in the interconnections between brain areas, which explain some of these behaviors. And so whenever we have a case like this, we want to do the advanced imaging to see what we can find.
And so was advanced imaging done in this case?
Yes, so we made sure that the data were collected in a way that would allow us to do the advanced imaging. And the advanced imaging is basically done by a computer. So what the computer does is it takes the brain and it basically turns it into a little Lego brain. It makes little tiny cubes known as voxels. And for each cube, the computer can look at it and determine how much brain tissue there is in the cube. And it can also, using a technique known as diffusion tensor imaging, it can measure something known as FA, which tells us about the integrity of the white matter. So what the computer is going to do for each of these little cubes is how much brain tissue is there and what is the FA value within the white matter. So this is all automatically done by the computer. The computer then automatically identifies regions of interest. So the computer divides the brain into 107 different areas for volumetrics, 48 different fiber tracks for looking at the white matter. And we have a large normative database. So again, just like is done in neuropsychology, you need to compare to neurotypical subjects. We have a large database, and the computer makes the comparison between the metrics for Mr. Cahill and age and gender matched subjects within the normative database. So all of that is done automatically. The only thing that the computer knows is Mr. Cahill's age and that he's a male subject. So does it know if it's my brain, the prosecutor's brain, or Mr. Cahill's brain? It's going to process things automatically in order to give as objective an evaluation as possible. So I'm going to talk initially about the volumetric data. I'm just going to show some data for what's known as Brodmann Area 4. This is the motor control center of the brain, and Brodmann Area 3, this is the touch control center for the brain. And what I'm going to show you here are the volume values for, there's 583 male subjects in our control database. Here are their ages. So each black dot represents one of the control subjects, and the red dot is Mr. Cahill. So what you can see for these two brain areas is he is right smack dab in the middle of everybody. He's basically within normal limits for those particular parts of the brain.
But it looks like the largest number of the normative subjects is over on the left of the chart. Is that what I'm seeing there?
It is. So the largest number tends to be in the younger age range. When we do the statistic evaluation, so you can see that there's a curve here. You don't want to be comparing him with the younger kids. When we do the statistics, we do that selectively on the subjects that are within plus or minus 10 years of age. So the mathematical evaluation only takes into account the subject in his age range.
So are we developing and over time increasing the number of subjects in the normative database?
So we are working on a new normative database that has even more subjects. Based on the statistics, there's 90 subjects within his age range. That is more than sufficient to identify even subtle changes in brain volume.
And I guess there are more younger, well, why are there more younger subjects in the normative database than older subjects?
So for our normative database, it's just been easier to recruit the younger subjects. So we're on, basically we're on a university campus. So we get university students, we get community individuals as well, but it's often a challenge to get in the older.
So students are the ones who have the time to come to your laboratory and sit in an MRI scanner for $100, right?
Yeah, so it's students, it's also individuals from the community, but again, younger individuals tend to be more willing to come in. It's easier for them to come for these studies.
People 65, they don't want to mess with it.
Correct.
All right. Okay, I'm sorry. I just go ahead and further explain what we're doing.
So I want to show you two other areas of the brain. This is an area of the brain that's involved in language. This is an area of the brain that's involved in memory. And so what you see here is instead of Mr. Cahill being up in the middle, he's way, way down off the mark. Yes, there are some individual control subjects older than he is who have similar findings, but he's very low in these brain areas. So we want a way to describe that and quantify that. That's where we use statistics. Many of you may have heard of the bell curve. So this is what the distribution of things looks like. And so what we can do, so again, we only look at the subjects within his age range, and we can determine what is the mean value, the average value. We can determine what is the variability in values, what's known as the standard deviation in the measures. And we can calculate something known as a z-score, which is the difference between Mr. Cahill and the average group divided by the standard deviation. That gives us a statistical indication of how far off from normal his values are. And we plot that on a strip chart, so we make these little bars, and for each individual region, if the bar is colored gray, it means you're still within normal limits. If the bar is colored reddish-orange, it means that the value is outside of normal limits, above the value, so in the highest fifth percentile. If the bar is blue, you're in the lowest fifth percentile. That's considered statistically significant. And the darker the color, the more abnormal it is. So I'm just going to show you here, this is actually a neurotypical control subject, okay? So what I want you to notice, first thing is most of the bars are gray, but there are a couple of bars that are a little bit outside of the statistical limit. And the challenge is that when you make 107 measurements, even for somebody who's completely neurotypical, you're going to get a few measurements that appear to be outside of normal limits. This is something known as the multiple comparison problem. We have a statistical technique that lets us correct for multiple comparisons. And when you do that for this neurotypical control subject, none of these values are still considered to be outside of normal limits. And that's what you expect. You want your neurotypical control subjects to be within normal limits. This is Mr. Cahill. So what you see here are lots of areas in blue, some with the very, very dark blue, so very far outside of normal limits. And all of these areas in blue are still significant after correction for multiple comparisons. So based on the quantitative imaging, Mr. Cahill has a number of brain areas that are abnormally small. And this shows the distribution of those areas. And the distribution is important. So what we see is he has lots of areas in what are known as the frontal lobes of the brain, the parts of the brain that are controlling things like executive function, decision-making, regulation of behavior. He also has abnormalities or what are known as the limbic system. These areas are involved in memory and emotional regulation of behavior. He has a very significant deficit in part of the hippocampus, and in particular the hippocampus on the left. This is a part of the brain that is involved in memory function. The reason that I'm pointing this out is that the pattern matters. So the fact that we're only seeing this abnormality on the left can help to tell us something about what the possible causes are, okay? Things like substance abuse, for example, in general produce changes in both sides. So a finding of selective deficit in the left hippocampus is not likely caused by something like substance abuse. As I mentioned, we also looked at the white matter pathways in Mr. Cahill's brain. So these are the interconnections between brain regions. The analyses are done basically the same way. We look at 48 brain areas. Again, neurotypical subjects won't show any abnormalities. Here's what we have for Mr. Cahill. So many, many brain areas, many regions where the interconnections have been disrupted. Again, what types of functions are we looking at? So for the volumetric findings where he's got small brain, these are parts of the brain that normally control things like memory, executive function, regulation of behavior, emotion, mood. All functions that we know based on his neuropsychological testing are compromised. So we have convergent validity between the imaging and his history and neuropsychological testing.
Meaning that when we read his history, we see the problems indicated by his history correspond to the areas inside his brain which would influence or control those behaviors.
Yes, so there's convergence in the expectations between the neurobiological neuroimaging profile and what we have on neuropsychological testing and based on history.
Now, of course, you know, we all know the old saw in the study of logic, correlation is not causation, right?
Correct.
And so how do we account for that or consider that when we're, I mean, this is a colossal amount of data we're pouring out to the jurors here. And so how do we know that we're not just seeing a coincidence in the data?
So again, the correlation and causation are difficult issues to resolve. We do know that you can have brain damage in areas, for example, that should be affecting things like language. And you can have individuals with okay language skills. And that's because the brain is plastic and can reorganize and sometimes compensate for damage. When damage is very, very severe, like we're seeing for some of the structures here, then you really do start to get a one-to-one. So somebody who has a hippocampus that is as dramatically compromised as it is here, if they didn't have memory problems, that would be a real shock. That would go against the neurobiological expectation. So again, in this case, we have fairly good convergence between data. It's suggestive of causality. It doesn't absolutely prove causality.
So go on with your discussion. What else did we observe?
And so again, similar to the volumetric findings, the white matter changes are also in areas of the brain that are controlling things like memory, executive function, emotional processing, also some disruption of visual processing as well in terms of the connectivity. And so kind of the last part of this is, why is the brain abnormal like this? What can we say about most likely causes? And again, those inferences are based on what we know from the scientific literature is likely to happen. I can't tell you with 100% certainty this is exactly what is going on for Mr. Cahill, but based on the literature, we can draw some inferences. And the first inference is that the ectasia, so that swollen blood vessel, the white matter hyperintensities, and the microhemorrhages most likely reflect his hypertension. That is the most parsimonious explanation with that particular set of abnormalities. He has some white matter hyperintensities that are what's known as the gray-white matter junction. That is suggestive of traumatic brain injury. It's not conclusive for traumatic brain injury. And as you've heard, there's some information which suggests that Mr. Cahill has had head traumas and traumatic brain injuries, but we don't have clear medical records on that. So there's a consistency and convergence here, but I can't look at this scan and say, aha, this has to be traumatic brain injury. I can look at it and say it has some consistencies with traumatic brain injury, but we don't have all the information.
All right, so before you go on to the next paragraph, let me ask a couple questions about that. Is it possible that traumatic brain injury could result from an impact to the head that is not some dramatic, horrible impact?
Yeah, so we absolutely know that traumatic brain injury can result from what appear to be relatively low impact forces. There's two parts to traumatic brain injury. There's what's known as the primary injury. So this is the damage that's caused by the actual physical forces. But those physical forces set into motion a series of biochemical and metabolic events and immunological events that develop over the minutes, hours, days, weeks, and sometimes months after a traumatic brain injury. So you can actually, even in the case of mild TBI, you can have consequences that aren't seen for several weeks or months after the injury. Now, that's not always the case. Again, it's very individually determined, but you can have secondary injuries that develop over time that cause loss of brain tissue, that cause certain types of lesions.
I mean, you know, going back hundreds of years, it wasn't fully understood exactly what the brain did, and they kind of found out about it by accident, right?
Yes, most of what we know about relationships between brain structure and function comes from studying when things go very wrong, when somebody has a stroke or a penetrating brain injury.
I mean, the very first guy they ever studied was some guy in the 1840s who was working on the railroad, right?
So one of the most famous traumatic brain injury cases is a fellow by the name of Phineas Gage. Phineas was a railroad worker, and his job was to tap down the blasting cap. And one day he became distracted, and he tapped on a blasting cap, and it went off, and it shot a 6-foot metal rod up through his cheek, up out the top of his head. He actually never lost consciousness. He found his way to a local doctor, but Phineas was never Phineas again. He had dramatic changes in his personality. He was no longer able to hold down a job. He became belligerent with his family. And he had damage to the frontal lobes of the brain. So a lot of what we know about the relationship between the frontal lobes and behavior comes from studying individuals that have very significant damage to the brain.
But we've learned since the unfortunate Mr. Gage that you don't have to have an iron rod shot through your brain to have a traumatic brain injury. It doesn't have to be that dramatic an injury.
Correct. So again, very subtle physical forces can still cause traumatic brain injury, and there are certain individuals that are especially susceptible to secondary injury from even mild impacts.
All right, so let's go on to the second paragraph about volumetric and DTI.
So again, from a neurobiological perspective, the volumetric and DTI data are clearly abnormal, and they're most likely multifaceted in origin. The findings certainly reflect to some degree Mr. Cahill's history of psychiatric dysfunction. The imaging findings are consistent with what you see for psychiatric dysfunction. The imaging data are also consistent with a history of head trauma and related TBI. Again, all I can tell you is that they are consistent with that at this point. We have some information to indicate that Mr. Cahill had head traumas. Again, I don't have specific medical records for those, but just looking at the imaging, these are the two things that are the most likely potential contributors. I can't tell you what percentage. I can't tell you with 100% certainty. What I can tell you is we do know that Mr. Cahill has a history of substance abuse. Substance abuse does cause changes to the brain, but it does so in particular patterns, and different substances actually have different patterns in the brain. We know that Mr. Cahill has a substantial history of alcohol abuse. The profile that we are seeing in terms of his imaging has some overlap with expectations for substance abuse, but it goes beyond that. So alcohol abuse in and of itself is not sufficient to explain everything that's going on in the absence of at least the psychiatric response. We've heard very briefly that Mr. Cahill has abused something known as DXM. This is a compound that's actually in cough syrup. DXM causes some changes in the brain. There's not a lot of data on it, but what's been reported in the literature is that DXM actually leads to an increase in brain volume in the frontal lobe. Mr. Cahill has a decrease. So there's a mismatch between DXM expectations and what we're seeing from Mr. Cahill. I think it is unlikely that DXM is contributing to the imaging findings that we're seeing. We've also heard that he has a history of LSD usage and marijuana usage. Those can cause abnormalities in the brain, particularly in the frontal lobes. The magnitude of what we're seeing for Mr. Cahill is beyond the reported magnitude for these substances. They may be contributory, but in the absence of these other factors, I do not believe, from a neurobiological perspective, that they're sufficient to explain what's going on. So we have a multifaceted situation. Clearly, the psychiatric dysfunction is on the table. There's probably some contribution from substance abuse, not sufficient in isolation. There's possibly some contribution from traumatic brain injury. We have some consistencies there, but we have some missing things in terms of medical records to know how many TBIs were there, what was the nature of those.
Was there anything else that you observed from your analyses?
No.
All right. So in summary, what are the findings that you made based on your examination and analysis?
So the summary is that there's a number of abnormalities, both gross structural abnormalities and more subtle volumetric and DTI abnormalities, that the profile of abnormality is consistent and convergent with historical information and neuropsychological testing on the types of deficits that are seen for Mr. Cahill. From an etiological perspective, some of these are clearly related, or most likely related to things like his hypertension. There are other findings where we can't be fully certain what the etiology is, but they are most consistent with major contributions from psychiatric dysfunction and possible contributions from substance abuse and traumatic brain injury. But substance abuse in isolation is not sufficient to explain everything that's going on.
And some of the images you observed have apparently been present since birth.
Yeah, so the subarachnoid cyst was most likely there since birth. And often those are benign, but they're not always benign. We don't have the additional data that we need in this case.
And earlier you characterized his brain abnormalities as very, very severe.
Yeah, so I meant, so in the grand scheme of brain abnormalities, they're on the moderate side. He doesn't have, a missing hemisphere or anything like that. But these are significant abnormalities. These are abnormalities where there's a good expectation that these are going to be associated with specific functional deficits.
So, I'm almost through. May I approach the witness, Your Honor? Yeah. All right, Doctor, you prepared a written report which summarizes or reports your findings. Is that correct?
Yes, sir.
Let me show you what's been marked as defense exhibit number 9. Is that your report?
Yes, sir.
Then we'll offer into evidence defense exhibit number 9. I think the prosecutor offered the same document for record purposes as agreed something yesterday. Maybe it's not exactly the same one.
Yes.
Just because I don't have a copy of this one, we offer $3.99 for all purposes. That's a copy of this.
No objection, and we'll withdraw it. We'll withdraw defense 9.
States 399 is admitted for all purposes.
Pass the witness.
Good morning, Dr.
Lewine.
Lewine. Good morning, Dr. Lewine. How are you?
Good morning. Thank you.
I'm tired. I'm tired and I'm about to run out of suits because we're on day 4. Hey, Judge, can we keep this PowerPoint up? All right. Dr. Lewine, was the PowerPoint clicker working for you?
On and off.
Okay. I may ask you to go back a little bit, okay? The way things work in these trials is we start off with somebody doing something, right? I mean, that's how we come into it.
And then we come, and then we, as best as we can, we try to evaluate that person, right? We send in really good doctors like Tony McGarrahan and Matt Clem, and you'd agree with me. You've seen both of what they've done, and they're professionals, and they do a good job.
Yes, sir.
Okay. And in fact, you heard me yesterday tell the jury, almost 99.9% of what Dr. McGarrahan found, we agree with, right? I mean, there's not any discussion about it. It is what it is, yeah. Right? Okay. Tell me, as best as you can, why do you think you get brought in?
So I'm brought in to show objectively whether or not there is brain compromise.
Okay.
To determine whether the brain imaging profile is convergent with the history and the neuropsychological testing, and to the extent possible, understand the most likely causes of the imaging finding.
Would you agree with me? That's really it, right? I mean, so that you can sit here and you can tell the jury, well, substance abuse or traumatic brain injury, or, I mean, it's exactly what you said. The question number 2, why?
Right.
Right?
Yes, sir.
And you understand, I mean, that's why you and I are about to talk for a little while, okay? Now, to this jury, that why may not matter, right? I mean,
may not.
If Bryan Cahill is the kind of person who's going out there and shooting police officers, they've got to keep the community safe. The why may not matter too much, right?
That's for the jury to decide.
But you'd also agree with me, we should protect our juries from hearing things that they really shouldn't. I mean, it's not fair. We bring in doctors, we bring in people with PhDs, and it's not, I mean, it's a lot for people to try to figure out through. And if it's not 100% good stuff, we need to be protective of our juries, right?
Yes, sir.
Okay. Mr. Haynes brought up the 1800s. If you would tell the jury what phrenology was.
So phrenology was the idea that if you were good at a particular skill or have a particular personality, that is going to be reflected in the size of brain areas. So let's say you're good at mathematics. The math part of your brain should be bigger than the math part of somebody else's brain. And the idea in phrenology was that increase in brain size would cause bumps on the head. So the idea in phrenology was that by feeling the bumps on the head, you could draw an inference about the underlying brain structure.
And in the 1800s, we had scientists and doctors who were allowed in criminal courtrooms, and they would talk to jurors. Just like, I'm trying to picture it in my mind. It's like just like this, some old antiquated courthouse, somebody did something awful, and they would bring in PhDs and medical doctors, and they would look at jurors and they would say, well, what we know now with the brain, I can feel somebody's head and tell whether they have this area large or this area is missing. And oftentimes the area that they spent time on was the area that controlled whether you do good or bad. And then they tell jurors in criminal setting, this person couldn't control their actions, have mercy, right?
That did happen, yes.
Can you imagine those jurors trying to weigh that, thinking that that's science, that's a real thing, right?
That was a scientific discipline at the time.
And it was scary. It's scary to think about now, right?
I would argue that now, by actually looking directly at the brain, we have gone a huge leap from phrenology.
I was hoping you were going to say that. We also had in the early 2000s fMRI, didn't we?
We still have fMRI.
Yeah, and it can be used in some ways, but you and your mindset group used it to determine psychopathy, didn't you?
I was not involved in that.
Dr. Cahill with mindset, right?
Dr. Cahill with...
And you still work with mindset, right?
Yes, sir.
Okay. Dr. Cahill with mindset in 2009 was going into courtrooms and saying using fMRI, he could tell whether someone was a psychopath, right?
That is not correct.
We've written books on it because let me ask you, sir, in 2009, did Dr. Cahill not testify in the Charles Dugan case, a person who was facing the death penalty for kidnapping, raping, and killing a 10-year-old?
Object to this line of questioning. Dr. Cahill is not a witness. What is the relevance?
Rule.
He went in there and said, based on fMRI showing people pictures and seeing how their brain lit up, he could tell whether they were psychopaths or not. Did he not?
That is not what Dr. Cahill said. What Dr. Cahill said, and again, I was not involved in this case, what Dr. Cahill said is that Mr. Dugan's brain had an fMRI imaging profile that was consistent with what has been seen in individuals with psychopathy.
And what he was doing, Dr. Cahill, in New Mexico, right, because he's just like you, he's a professor in New Mexico and he gets his research funding. He was going to a prison and showing people that registered high on psychopathy pictures and then seeing where their brain lit up. And he was going into courtrooms and saying, based on whether their brain lit up with the right pictures, I can tell you whether they're a psychopath, right?
Again, he was not concluding that they were a psychopath. He was concluding that they had an imaging profile that was consistent with psychopathy.
Kind of like I'm not really concluding this is a TBI, but I'm saying it's kind of consistent with a TBI based on me putting stuff in a computer, right?
Again, I certainly see where you're going. The structural imaging of this type is much, much different from the functional MRI. I don't use functional MRI for these purposes. There are limitations there.
Dr. Cahill, your colleague who you work with at Mindset, currently, not back in 2009, now, right?
Mm-hmm.
Yes?
Yes.
Okay, all right. I bet in 2009, we're not talking about the 1800s, Dr. Cahill, like you, I'm a professor, I've got a PhD, I'm at the University of New Mexico teaching people, let me put on a PowerPoint. I'm sure that jury was pretty wild, right? Don't you think?
I wasn't there, I don't know.
Speculation is irrelevant.
I'm calling you doctor because you have a PhD, right?
Yes, sir.
Okay. I'll let you in on something that happens at my house. My wife is an OB-GYN. I have joked with her about asking her to call me doctor because I've got a Juris Doctorate. How do you think that goes?
I don't know.
Not well. You did not go to medical school.
I did not go to medical school.
You did not complete a residency in radiology.
That's correct. I teach residents in radiology.
Right. Again, my question wasn't, do you teach people in radiology?
I'm not a radiologist.
You're not a medical doctor.
Nope.
And because you're not a doctor, you're not bound by the same guidelines and principles that bind radiologists and neuroradiologists within their governing boards.
I am not formally bound by those rules. I follow those rules.
You follow those rules?
Yes, sir.
You believe that volumetric analysis and DTI analysis are proper in diagnosing TBIs?
In diagnosing TBI, no, not in isolation.
Okay.
They are pieces of a puzzle.
They've been found by those boards. I'm sorry. Please listen to my question before you start shaking your head and trying to answer. You're not bound by those boards, right?
Not formally, though.
Okay. So like my wife, she is a member of the American College of Obstetrics and Gynecology, ACOG, right?
Yes, sir.
And they set guidelines so that when she...
Question, the prosecutor is testifying.
So what are the boards that bound radiologists and neuroradiologists?
So there's the American College of Radiology.
Let's just go with that.
Okay.
The American College of Radiology. What they do is they set guidelines. So doctors will go and they will, if someone presents with certain, whatever it is.
In proper form of the question, the prosecutor is testifying.
Judge, this is an expert witness. They go and they have to follow those guidelines. So where they say if someone presents with this, these are the proper tests to perform, this is the proper way to look into it, right?
Yes, sir.
And if they don't use those, they're looking at lawsuits and possibly losing their licenses, right?
Yes, sir.
Right. Okay. And they set forth, and I understand you're going to distinguish between diagnosing and what your work is, coming in here and testifying in front of people, but you would agree with me that you can't diagnose someone, right?
That is correct, sir.
Not a doctor.
That is correct.
So looking at those images and telling us what they mean, Dr. Snyder had to do that, right?
Dr. Snyder did that for the gross neuroradiological findings, yes.
Okay. You actually, I know that you look at them, but really what you're testifying to with regards to volumetrics and DTI, that's, if I understand it correctly, those images are being put into a computer. That computer is measuring very fine, things that we couldn't do with our own eyes. It's measuring the brain in different ways, as you explained, and then it puts out those results as an analysis, and then you look that over and you check it and you make sure this is how we interpret it, right?
Yes, sir.
Okay, so it's not you really looking at pictures of the brain, it's the computer looking at it and spitting out a product, right?
Yes, sir.
And the one you use is what? The program you use?
Oh, it's a combination of something as SPM12, FSL, and MATLAB.
And I could go on my computer right now and I could get those programs, right?
Yeah, you have to pay for some of them.
Oh, they're not free surfer programs?
No.
Some of them are.
Some of them are.
And none of them are FDA approved.
They are not FDA, so they don't require FDA approval, but they are not FDA.
To answer my questions. Are they FDA approved?
For what?
At all?
No, they've never been submitted for FDA approval.
Right, okay, so when I asked you, are they FDA approved, the answer is no.
No.
Okay. You agree with me, there are FDA approved programs within volumetrics that we use a lot of times in Alzheimer's.
Yes, sir.
Okay. Yours aren't. Some of yours are just the stuff I can get off the internet.
They use the same general algorithms that are in the FDA approved. We've not submitted for FDA approval.
Let me repeat my question. Yours are not FDA approved, and some of yours you said I can get off the internet for free, right?
You can get pieces of it, yes.
What year, model, and software version was used on the scanner for Bryan Cahill scans?
On the scanner for collecting the data. So he was scanned at Prime. So it's a GE. I don't recall the model.
Okay, you don't know what model it was. I mean, I know it's a.
I have the information. I don't know it off the top of my head.
Well, you know what model it was. Do you know what software version it was using?
Again, I have that information. I don't know that off.
Was it the same model and software version that was being used by the ones on your subject group?
No. So we do something. No.
You said no, right? All right. I understand. There's computer programs, blah, blah, blah. The answer is no, right?
Correct.
Okay, thank you. You remember doing similar testing in the Roger Harris case out of Dallas? He had been given the death penalty, and you sent in a report?
I don't recognize that, but...
Can I approach, Judge?
I may have. I don't recognize that name.
Just so you don't think I'm asking about something you didn't do. Is that your work?
Yes, sir.
Okay, can I have it back?
Yep.
And I'm not gonna, don't worry, I'm not gonna ask you about, like, specific things, but if I were to tell you in Roger Harris, you did this testing on someone who you said was subject to fetal alcohol syndrome, gross, all kinds of problems growing up, low IQ, all of that kind of stuff. I mean, does that sound about right?
Again, I don't remember the specific case,
Right.
but I can certainly believe that that's correct.
Alcohol-related neurodevelopmental disorder, lead exposure, complex trauma with exposure to domestic violence, ADHD, learning disabilities, and then the TBIs.
Yes, sir.
Okay. And you did the same testing you just showed the jury on Roger Harris, right?
Yes, sir.
Without going into what he did, I mean, probably really bad stuff, death penalty case, right?
Yes, sir.
All right. Totally different set of issues, though, right? I mean, like, we're talking about someone who had, fetal alcohol syndrome, lead exposure, maybe not. Exposure to violence in the home. The big-time stuff you were talking about with that picture of all the things that can lead to it, right?
Yes, sir.
As opposed to Bryan Cahill, who, he's got a 129 IQ in 5th grade. He's, even now, average to above average IQ of 94. A lot of difference in life. I'm not getting to the brain scan stuff yet, but a lot of differences in life, a lot of differences in the kind of person we're looking at, right?
Yes, sir.
Okay. Would it surprise you if your testing showed 44 out of 108 regions on Roger Harris were abnormal as 30 out of 107 on Cahill?
No.
Would it surprise you if you had 25 out of 48 fiber tracks for Harris and 21 out of 48 fiber tracks for Cahill?
No.
That wouldn't surprise you?
No, sir.
Right, because we see what we see.
Yes, sir.
All right. Would it surprise you if you managed to rule out all of the things in Mr. Harris' decision points with regards to what contributed to his brain damage, just like you did in this case?
I'm not sure I understand the question.
Well, let me be very clear. Your report, you made sure in your conclusions in your report to say kind of what you told the jury. The screen right here, right? I mean, we've got a whole paragraph of why, hey, him taking all these substances, they don't count, right?
I didn't say they don't count. They're insufficient in isolation to explain things.
And in your report, you wrote it this way. To a reasonable degree of neuroscientific certainty, and more likely than not, it's the expert's opinion that he demonstrates a substantial brain compromise, the majority of factors outside of his easy control.
Yes, sir.
Okay, that's not just now we're starting to make some values on the stuff we see with his brain damage. I'm attributing to stuff that it isn't his fault, right?
That was my conclusion.
And that's why you're here, right?
That was my conclusion, yes.
All right, can you jump back to the imaging? Let's talk about the imaging real quick. May I approach, Judge?
Yeah.
Which one are we on this one?
That's Acacia.
Acacia. Tell the ladies and gentlemen what relevance that has in any of the events on 2019.
I'm not convinced it has relevance.
From a neurobiological standpoint, that has nothing to do with what we saw in 2019.
It's possible it does. I don't have any explicit links there.
Didn't you make a PowerPoint where you said it has no relevance?
Yeah, I wouldn't use the word no relevance, but there's no direct link between this in the events. I think that this is an unlikely contributor.
From a neurobiological perspective, these particular findings are unlikely to have played significant contributory role in the March 2019 events.
And I agree with that.
And there is a population within people walking around the world that have that would look exactly like that on imaging and have no symptoms from it.
Absolutely.
Okay. Why are we showing the jury that one?
I'm presenting the data. My role is to present the information on what we had as abnormalities, and I have explained to the jury that I don't think that that's particularly relevant.
So we're putting stuff about his brain in front of this jury that's not relevant.
That I'm not sure has relevance to the incident of fact.
Not to try to bring out the emotions when we're looking at his brain and, oh, poor Bryan Cahill, right?
My job's to show what I saw.
Let's go to the next non-relevant slide then. What's this one?
This is the acoustic neuroma. I also don't think this is especially relevant.
No, let's start. First off, that's an antiquated term, right? It's a schwannoma is the way we call it nowadays, right?
It's called both.
At worst, we're looking at headaches, loss of hearing, and balance problems.
Yes, sir.
80% of acoustic neuromas are treated by observation.
Yes, sir.
Don't do anything with it. In the very worst cases of acoustic neuroma, well, let me take that back. The next, 10%, 15% radiology, right? We can treat it with radiation, right? And then the very, very small percentage of the small percentage, there's actually, we go in and we do surgery.
Yes, sir.
Okay. And you're not aware that UTMB, the health systems within the prison have all of those capabilities. You don't know that?
I believe that they do, but I don't know.
All right. Tell the jury what relevance this, because you use the word tumor, and I want to be real clear about this. Tell them the relevance of that tumor on this case.
I'm not convinced this has relevance.
Because it doesn't have anything to do with behavior, right?
In general, no. That's correct.
I mean, other than being upset that you're either losing your balance, hearing ringing, having headaches, it has nothing to do with behavior, right?
Yes, sir.
Okay. So, the real reason that the MRI was being asked to be done in this case was in case he had a real brain tumor, because those can affect behavior, right?
Yes, sir.
Okay. Did we see any real brain tumor?
Again, this is a real brain tumor, but it's not the type.
Well, this is an auditory tumor, correct?
It's on the auditory nerves. It's not in the brain. That is correct.
And So why are we showing them that picture?
And I am showing the information that I had. I actually had slides that were explaining some of this detail that I was asked to remove.
Well, because they weren't relevant, right?
I was pointing out that they weren't relevant.
Okay.
But as a scientist, I still need to show what I saw.
It wouldn't be so that maybe, again, the jury feels bad for poor Bryan Cahill because he has a tumor in his head. I'm
happy to have this discussion about the relevance of these things. I was showing what I saw.
Okay, I appreciate that. Let's go ahead and go to the next non-relevant one. Subarachnoid cyst. That happens in birth, has nothing to do with behavior.
So subarachnoid cyst, if there is epileptic activity that is associated with it, can have an impact on behavior. We don't know whether there is epileptic activity.
If Bryan Cahill, I mean, with the medical records you've had, with the mom he's had, with the team that he's had, if Bryan Cahill suffered from epilepsy, you think you'd hear about it?
If he suffered from clinical seizures, you can have subclinical epileptiform activity that masquerades as psychiatric dysfunction. Again, I don't have the relevant data in this case.
So if there's nothing in front of you, I mean, you would agree with me, there wasn't a lack of trying to get you information to put together in your presentation, was there?
No, this is a case, however, where an EEG might be informative.
This was one of the ones you put down from a neurobiological perspective. These particular findings are unlikely to have played a significant contributory role in March 2019 events, too, right?
Yes, sir.
Okay. Again, there's many Americans walking around our society right now with subarachnoid cyst, and it doesn't affect one single aspect of their life.
Absolutely.
Okay. Let's go to the next one. Okay, this is where we get to the white matter hyperintensities. You'd agree with me, just from the beginning, we'll get particular here in a second, but from the jump, many Americans walking around with white matter hyperintensities that have nothing to do with their behavior, right?
Absolutely.
Okay. One of the ways is over time we develop those.
Yes, sir.
Don't know why.
Correct.
I mean, and you'd also agree with me, there's a lot about the way the brain works that we don't know why, right?
Yes, sir.
I mean, when Dr. Cahill was doing all his work with those pictures and parts of the brains would light up, we now know, like, you can't pinpoint it. Parts of your brain lights up for different reasons, and we can't say, well, this is because you're happy or this is because you're sad, right?
Partly true. So we talked about Dr. Cahill's work. There's not evidence that what Dr. Cahill said is not correct.
Okay. All right. I'll tell you what. I'll move on. I don't want to get bogged down with that again. All right. So we've gone over the ectasia, the neuroma, the hyperintensities. You said, is this the one you kind of rest your hat on? Is TBI?
No. So it's possible TBI. In isolation, TBI is a likely explanation of this. It could be hypertension, and as I discussed, the TBI history is a little bit unclear here.
Out of all the imaging that we saw, if you're gonna say this one to me was more readily explained from TBI than any of the other ones, it was this one, wasn't it?
In terms of the gross findings,
yes.
The volumetric findings are also suggestive of TBI.
Okay. So you're testifying to this jury that you would expect white matter hyperintensities with TBIs?
So white matter hyperintensities near the gray white matter junction are consistent with the history of TBI.
Okay.
Let's take our morning recess. Please be back in the jury room at 10 minutes after 10.
All right.
Yeah, thank you. How's it going? Good.
Mr. Mitchell, still your witness.
Dr. Lewin, I think you changed slides on me while
Yeah,
I
I
was
was
in.
checking something and now it's not working to go back.
I'd like you to go back, sir.
Trying, but the clicker does not seem to be. There we go.
All right. Okay, so we were on white matter hyperintensities. Let's be done with that. Let's go to the last one. And these are the microhemorrhages, right?
Yes, sir.
You said this is most consistent with what?
Hypertension.
Hypertension. Someone who's not taking their meds. We're going to see this, and that contributes to brain problems, for lack of a better term.
Yeah, it causes microhemorrhages.
Okay. I don't have a lot more questions. One of the things in this case that I don't believe you mentioned, right? You mentioned substance abuse, you mentioned head trauma, you mentioned psychosis or psychotic mental illness. One of the things you didn't mention is smoking. Can smoking have an effect on the brain?
So smoking does have an effect on the brain. It can cause some very minor reductions in brain volume. And the FA data, actually, there's conflicting data about whether it's high values or low values. The magnitude of the changes associated with smoking are order of magnitude less than what we're seeing in this case. Could smoking be contributory? Yes, to a very mild degree, not sufficient to account for the types of changes we're seeing.
Okay, and you keep seeing changes, and I'm going to talk about that in a second, but so you decided just not to include it?
It's below the threshold of things that I list. So, for example...
Okay, I heard the answer. It's below the threshold of things you list. If a neuroradiologist testifies to this jury that smoking can have effects on DTI and FA values like anything else, you would disagree with that?
No, I said it can have effects, but they are very small in magnitude compared to what we are seeing here.
And if all the small things added up in a it doesn't work that way.
It's still not sufficient in this case. So his hippocampal volumes are down more than 30%. Smoking can account for a change of maybe 1%.
Okay. So let's talk about what you just said there. Okay. So just so we're clear, in your mind, man, all the stuff that he did to himself, that doesn't really count. It's got to be the big stuff, the head traumas and hypertension, right?
No, so the alcohol abuse could be contributory here. It is not sufficient in and of itself to explain everything, but I believe that it's reasonable to posit that there's a contribution from the alcohol.
Sure. You keep saying changes to the jury, right? So we're clear. You don't have imaging from Bryan Cahill at 10 years of age, 20 years of age, 30 years of age, right? I mean, like, when you say changes, you're talking about compared to the norm.
Yes, so we use the norm as an inference on what he would look like if we had that imaging. And
so the jury understands. You keep saying his brain's changing. What you're saying is his brain compared to what I'm considering a norm, right?
Yes, sir.
And you'd agree with me, and I'm not talking about all the way. I'm talking about big picture now, not the volumetric or the DTI, but big picture. All of our brains look different, right?
To some extent, but there's also a lot of similarities.
I mean, it's an organ like anything else. Like, I've got freckles that you don't have, and my finger, I may have small hands, you may have big hands. I mean, like, the body is wonderfully and fearfully made, and everything's a little different, right?
Yes, sir.
Okay. The truth is, though, and let's just end here. I think we can agree on a couple things. The truth is, you can't look at somebody's brain and determine behavior, right?
I didn't hear the last part of the sentence.
You can't look at somebody's brain and determine behavior.
No, you can make inferences about what behaviors may be affected, but if you want to know about behavior, you directly test behavior.
You can't look at someone's brain and say, this person's dangerous or not.
No, sir.
You can't look at someone's brain and say, this person's going to be dangerous in the future.
That is correct.
You can't look at Bryan Cahill's brain and say, watch out, we couldn't have gone back in time and said, watch out, trooper, Bryan Cahill's got a brain and he's likely to shoot you. Couldn't do that.
No, sir.
So Bryan Cahill's brain, it is what it is at this point as he sits in this courtroom, isn't it?
Yes, sir.
And all the imaging, all of the testing you've done, it may have something to do with what the doctors have found as far as why he's not good at certain things and why we see low cognitive functioning. But as far as explaining why he is who he is out in society, that's not your role.
That's correct.
And quite frankly, you can't tell this jury anything about what he's going to be in the future.
That's correct.
I'll pass the witness.
No further questions.
Is this witness released?
He is released.
Thank you, sir. You're released. You're free to stay or go, whatever you'd like to do.
Thank you.
Defense, call your next witness.
Defense called Matthew Clem.
Sir, if you could please come up to the bench so I can swear you in. Raise your right hand for me, sir. Do you swear or affirm that your testimony will be the whole truth and nothing but the truth, so help you God? Thank you. Please have a seat.
What's your name, sir?
My name is Matthew Clem.
And you are correctly referred to as Dr. Matthew Clem, is that correct?
Yes.
Dr. Clem, what is your profession? What is your work?
I am a clinical neuropsychologist and forensic psychologist.
Briefly explain for the jury what the educational achievements are that allow you to do the work that you do.
So I have bachelor's, master's, and a doctoral degree in psychology, and completed a 2-year fellowship in clinical neuropsychology, and I'm in independent practice in Dallas.
And when did you complete your training?
I completed my fellowship in 2019.
So you have recently completed your training, and now you're working in the profession.
Correct.
You work with Price Proctor, a very well-known group of clinical psychologists in this Northeast Texas area. Is that correct?
Correct.
And what generally is the business of the practice?
The practice in general, we have psychologists and neuropsychologists, but generally the vast majority of individuals that we see are for evaluation and assessment, and these are usually individuals involved in the legal system somehow, and then a significant portion of our work involves occupational evaluations, pre-employment screenings, fitness for duty evaluations, and of the like.
And were you asked to evaluate Mr. Cahill in this case?
I was.
How did that come about?
Dr. Proctor, who's also at our practice, had been retained on this case, and it became apparent that a neuropsychological evaluation was needed. And Dr. Proctor is a forensic psychologist and asked me to assist on the case and do a neuropsychological evaluation.
And so in order to do that evaluation, what were the steps that you followed? Well, first of all, did you review any documents or other materials?
I did. I reviewed.
So what did you look at?
Fairly extensive documents from offense reports and very limited mental health records and some legal records from prior involvement with the legal system, as well as Dr. McGarahan's raw test data. And I think that generally encompasses what I've reviewed.
Watch any videos?
I did watch numerous videos of the offense, and interviews that had been conducted with the defendant's mother and brother.
And that material came from Dr. McGarrahan, the interviews with the defendant's family?
No, these were interviews by law enforcement on the day of the offense.
But you did have access to Dr. McGarrahan's material?
I did not have access to the interview notes prior to writing my report.
But to the test results, is that correct?
Correct.
And you're a psychologist too, so you also did some tests. You directly interviewed Mr. Cahill and you did some tests, is that correct?
That's correct.
How many different tests did you do?
Upwards of 30, similar to Dr. McGarrahan's evaluation.
Right. And did you do some of the same tests?
I did repeat some of the same tests and additionally gave some new tests that had not been given.
And you were here yesterday when Dr. McGarrahan testified, is that correct?
Correct.
And you heard the conclusions that she reached based on the evaluation that she did?
Yes.
Right. Do you find yourself in agreement with her conclusions?
I do. I think generally we found many of the same things and share significant overlap in our opinions. And
so, from a psychological point of view, what are your conclusions about Mr. Cahill?
Well, I diagnosed Mr. Cahill with an unspecified personality disorder, as well as with a psychotic disorder, the nature of which at the time my evaluation was not entirely clear, but appeared to be mainly characterized by paranoia and delusions.
And so paranoia is an unreasonable fear of almost anything, right?
It can be, yes.
And delusions are belief in things that aren't true.
Yes, more so being out of touch with reality. Yeah.
And Dr. McGarrahan was able to conclude and asked for additional evaluation to be done to take a look at physical brain damage. Is that correct?
That's my understanding, yes.
And do you agree that it was appropriate to do that, to look for that?
Yes, that's often a recommendation following a neuropsychological evaluation, is to recommend neuroimaging.
And did you see the same things in the outcome of your neuropsychological examination that indicated the need for imaging?
Generally, I would say yes, although the validity of my results was questionable given his approach to evaluation and the effort he put forth. So I would say generally, but my interpretation of the results I obtained was limited.
I mean, she had trouble in interviewing Mr. Cahill, right?
I believe so, yes.
And you had even more trouble, right?
That's fair.
Because you were there at the request of the prosecutor under the auspices of the court, right?
I believe that's part of it. I also believe the timing of the evaluation, which was just several weeks before his trial, likely played a role.
So, all right. Thank you, Dr. Clem. No further questions.
Morning, Doctor.
Morning.
And just so the jury understands, you were sitting, Super Web's mom's behind me right now, but you were right there during Dr. McGarrahan's testimony. Did you get to watch Dr. Lewine? I don't remember.
Not yesterday, but a little bit this morning.
Okay. But just so the jury understands who you are, when the state was informed that Dr. McGarrahan was going to get to go perform evaluations on the defendant, that allowed us to file a motion with the court to have you go talk to him and do your evaluations. so the jury understands where you're coming from. You were hired by us.
Yes.
And to give credit where it's due, where I wouldn't have had to otherwise, a lot of my ability to talk with Dr. McGarrahan and sound like I actually know what this stuff means is because you've been there kind of walking me through neuropsychology and etiology and a lot of this stuff we've been talking about, right?
Correct.
So you're kind of the unsung hero of us trying to get to the truth.
If you want to call it that, sure.
Okay, fair enough. But I told you, and so yesterday, just so the jury didn't think we hid you, at the end of Dr. McGarrahan's testimony, you and I actually stood there, and did we have a discussion about how long this jury trial's gone and whether or not you were going to add much other than what Dr. McGarrahan had already testified to?
Yes, sir.
And was the decision made, you know what, we've been here a long time, we've made our points, Dr. Clem, thank you for your service, but I don't plan on calling you.
Yes, sir.
Okay.
The defense is decided to call, right?
Yes, sir.
And I warned you, if the defense calls you, I'm going to use you like a rented mule, didn't I?
Yes, sir.
You ready?
I'm ready.
Okay. Mr. Haynes asked you about the sources that you reviewed. I think some of those sources were the same that Dr. McGarrahan talked to us about, but you watched videos, right?
Yes, sir.
You watched the offense video?
Yes, sir.
And then you told Mr. Haynes, he asked you about interviews. You watched interviews that were done by law enforcement on the day of the offense?
Yes, sir.
Okay. One of those videos was made with an individual named John Cahill. Is that correct?
Yes.
Who was John Cahill in relation to Bryan Cahill?
John Cahill is the defendant's older brother.
And did you use that video in trying to come up with what we're dealing with Bryan Cahill?
I did.
And during that video, so the jury didn't think I made it up, during that video, did John Cahill speak of some of the symptoms of Bryan Cahill's illnesses?
Yes, he did.
And was one of those symptoms the fact that Bryan Cahill believes that a 6-year-old was saying things of a sexual nature to him?
Yes.
What's the proven treatment to treat people who sexualize children? What's the way that we know that we can treat them and it'll end?
There's not a single proven treatment. Typically, sex offender treatment for those who have committed some kind of sex offense involves psychotherapy and behavioral modification, although it's certainly not 100% effective, and oftentimes it's ineffective.
He talked to you. Well, he talked to you about the offense, right? You tried to talk to him about the offense.
I did attempt to discuss the offense with him, and he was reluctant to go into detail, but described general events leading up to the offense and shortly afterward.
Mr. Cahill, don't make me warn you again. I don't want to hear any comments on the questions or the answers, and certainly not any profanities. You understand me? You're not sure? I don't want to hear your voice in this courtroom unless you're testifying. Do you understand? Mr. Mitchell.
Were there areas that you tried to talk to him about that he would not discuss with you?
Yes.
Did he try to control the conversation often?
Yes.
Did he blame, in your discussions with him about offense and some of the things that have happened in his life, did he often blame others for where he is and what happened to him?
Yes.
Would you describe those behaviors as manipulative?
During the evaluation, yes.
Are some of those factors that you considered with regards to your personality disorder finding?
Absolutely.
Okay. And if you would, I think we tried to do a little bit of it yesterday, but can you describe, I think two of your findings were possibly antisocial, possibly narcissistic. Can you kind of describe what those mean to the jury?
Sure. Antisocial personality traits generally involve someone who doesn't adhere to social norms, has a tendency to be aggressive, impulsive, and has a lack of remorse about the things that they've done. Someone with those traits tends to have difficulty maintaining employment, kind of participating in the typical achievements of adulthood in terms of work and life and relationships.
Go ahead. I'm sorry.
Go ahead.
No, were you finished?
Well, I was just going to address the narcissism.
Please do. I'm sorry. I thought you were done.
There's a lot of overlap in those two, but someone with narcissistic traits is very focused on themselves, has grandiose beliefs about their abilities, expects respect and admiration, and that's kind of the flavor of those.
And in both in both instances, we have features where there's either a lack of empathy or a lack of recognition of other people's feelings. Is that right?
That's correct.
And that's one of the features that makes people with antisocial personality disorder especially so scary. Is that fair?
Fair.
And there is no proven treatment with regards to antisocial personality disorder.
No.
I'll pass the witness.
No further questions?
Is this witness released?
He is released.
Stay.
Thank you, sir. You're free to stay or go, whatever you'd like to do.
Please, the court, members of the jury, the defense rests.
The defense has rested. What says the state?
Judge, we would request 5 minutes just to talk on yourself.
All right. Members of the jury, I'm going to send you back to the jury room, hopefully not for long. We'll bring you back out. Thank you.
All right. Judge, so that you and know, you're going to call one rebuttal witness who wants to be joining us by the next meeting. All right. Judge, we're being told that our rebuttal witness is actually on a phone call right now, and we're off that phone call. All right, I'm ready to thank you. Mr. Mitchell? Yes. Step up here and speak to your
Mr. Penn, can you hear me?
Good morning, Your Honor.
Good morning. Give me one moment, please. I'm going to make it so that you're visible in the courtroom, and we'll have to stand by so we can bring in the jury.
Yes, Your Honor.
Court officer, can we have the defendant seated and also please bring in the court? Please be seated. The defense has rested. It's my understanding the state has a rebuttal witness. Please call that witness.
State calls Dr. Joseph Penn.
Dr. Penn, could you please raise your right hand for me, sir? Do you swear or affirm that your testimony will be the whole truth and nothing but the truth, so help you God?
I do.
Thank you.
Good morning, Dr. Penn.
Good morning.
Can you hear me okay?
Yes, ma'am.
Okay. Will you please introduce yourself to the jury?
Good morning, everyone. My name is Dr. Joseph Penn. It's Joseph Penn, Penn, like Pennsylvania. I'm a psychiatrist. I'm trained in adult psychiatry, child and adolescent psychiatry, and forensic psychiatry. I'm board certified in all three, and I'm coming to you from North Houston. And thank you to the court for allowing me to do this virtually. I appreciate that.
And Dr. Penn, what do you do for a living?
So I do a couple of different things, but I'm a full-time state of Texas employee. I work for the University of Texas Medical Branch, and I work specifically in their correctional managed care department or division. And in my job, I'm the director of mental health services. So, and I can explain more what we do. We do really three different things, but that's my day job. My day job is Director of Mental Health Services for UTMB, University of Texas Medical Branch, Correctional Managed Care.
Okay. And the reason that you're here to testify is a lot of times people think that if somebody goes to into the prison system, that medical care and mental health care stops at the door and they do not receive that. Will you be able to provide some insight into the services that are available to inmates once they enter the prison system?
Yes, I will do my best.
Okay. Tell the jury a little bit about the training and education that you've received in order to have the position that you have.
Certainly. So I'm a native Texan, born and raised. I went to medical school. Well, I did college in San Antonio, Texas. I got my Bachelor of Science degree in San Antonio. And then I went to medical school at the University of Texas Medical Branch. And then I went off to Rhode Island and did my adult psychiatry and child psychiatry there. Uh, the adult was 4 years, the child psychiatry was 2 years, and that was at Brown University in Providence, Rhode Island. And then I did a 1-year fellowship in forensic psychiatry. And forensic psychiatry has to do with exactly what's going on right here in the courtroom, either civil or criminal cases, and then also working in corrections. And so since 1998, 1999, I've been working pretty much exclusively 20 plus years in correctional settings, jails, prisons, juvenile corrections, and mainly state prison settings.
And you sent me an email to your curriculum vitae, is that right? And it's
Yes, ma'am.
several pages long. It's about 29 pages long, right?
That sounds correct, yes.
Your Honor, State offers State's Exhibit 400, which is the curriculum vitae for Dr. Penn, after tendering same to defense counsel for objection.
No objection.
It's admitted.
Now, Dr. Penn, you said that you pretty much immediately went into the correctional part of medical care. What made you want to do that? What made you want to specialize in that area of medicine?
Yes, so a couple of things. One is individuals that end up in the court system are unfortunately have adversities. They have challenges both, in life and family, and they engage in risk-taking behaviors. But what I see is my role is we are pretty much like the State Hospital of Texas. We provide care for individuals, whether they're juveniles or geriatric, whether they're females or males or transgendered, or whether they're pregnant, diabetes, insulin dependent, they need dialysis. We can't say no sheriff, no jail, county jail, we can't take your patient or individual. We have a duty to provide access to care and continuity of care to all individuals that come to our state prison system. And it's not our state's prison system, it's the Texas Department of Criminal Justice, but we're the healthcare provider for TDCJ.
And will you tell the jury a little bit about the prison system, healthcare system in general, just how it kind of works, how it's built, that kind of thing?
Certainly. So it came to be through lawsuits and litigation that back in the 1970s, the healthcare was pretty bad in the prison system. And as a result of lawsuits, the Texas Department of Criminal Justice decided to contract, and it's by statute, by state law, that Texas Tech does out in West Texas, like Amarillo and Lubbock and El Paso. They do about 20% of the state. And then UTMB, we do 80% of the state. And we provide everything: nursing, medical, mental health, psychiatry, dialysis, specialty care. If somebody needs surgery or they need an emergency room, we provide all of that. We oversee all of that. We also provide health care to individuals that might be transgendered or on hormones. So we provide everything from the second that somebody hits the door and up until the time that they're released. And we assist with aftercare and follow-up. So I'm happy to answer more questions about either the medical, dental, or nursing, but in particular, my area of expertise and the area that I'm responsible for is the mental health care and the psychiatric care that's provided by our healthcare staff.
Okay. Talk to us a little bit about what the intake process is like. So when somebody enters the prison system, what does it look like in evaluating them so that they can have their needs met when they hit the prison?
Certainly. So the important thing to take away is that it's a multidisciplinary process, and there's a lot of safety nets in place and checks and balances. So when an individual comes to us from a county jail, and I'll explain more about how we verify information, because unfortunately, a lot of times it's self-report. And if I tell someone, no, I have no history of mental illness, and no, I've never been hospitalized, and no, I have no history of a suicide attempt, and no, I've never been to the state hospital, we have ways to verify all of the above. But basically, when someone shows up into our prison system, they've already received evaluation and diagnosis and treatment in the county jail. And that information is shared with the Texas Department of Criminal Justice. And I can go through more specifics, but there's actual forms that have to be filled out by the county jail. And there's a term called they have to be state ready. And what I mean by that is the county jail has the burden or responsibility to fill out a bunch of paperwork, medications, allergies, diagnoses, what treatments an inmate is receiving in county jail. And then that way they don't just show up on our doorstep and we don't know anything about them. We have individuals that might show up that are on dialysis and they need to continue their dialysis, or they're on HIV medicines or hepatitis C medicines or psychotropic medicines. So we need to make sure that continuity of care continues. So from a manpower perspective, when the individual comes in, correctional officers will let us know if someone is acting strange or odd or unusual, and they kind of jump to the front of the line and they're referred immediately and they're seen by a nurse. We have nurses on site at majority of our prison units, and in particular at the intake units. So getting back to the multidisciplinary piece, they're seen by TDCJ staff, custody and classification, to figure out if somebody might be in a gang or if they have security threat group risk, or if they're, violent risk or that sort of thing. But our nursing staff does a nursing intake health assessment, and I can say more about that. And then eventually they're referred to medical and they undergo a physical examination. They would undergo blood work to rule out sexually transmitted diseases or tuberculosis to see if they have TB. They get a skin test. So there's all these things that are done. And then they're referred to mental health and they're screened by mental health. And then they could undergo additional mental health evaluations and or psychiatric evaluations if needed. So it's basically a complicated process, but there are those checks and balances in place.
Okay. So you get all of the information from the county jail that gets to you before the inmate ever gets to you. And then once they get to the prison system, they actually are evaluated independently as well. Is that right?
That's correct. And if I could clarify, they're evaluated both by custody, classification, and then also they're evaluated by nursing staff. And those are UTMB nurses or Texas Tech nurses that would see them. And they would undergo an intake health assessment. They would be asked a series of questions. There's an assessment if they're suicidal, if they're homicidal, if they're thinking of hurting themselves or hurting someone else, if they're hearing voices. And so what medicines are on, what allergies they have, all of that is verified. And then there's an additional level of protection, which I can say more about in a second. But it's kind of like if you go to the doctor's office or you go to an emergency room, it's the same type of questions that they would ask you.
Can you talk to us a little bit about the mental health screening? What does that look like?
Yes. So the standard intake assessment that's done by nursing comprises of questions that raise mental health questions like, do you have a past history of mental health problems? Have you ever attempted suicide? Are you thinking about suicide now? Have you had recent losses? Are you hearing voices? I mean, those are just some simple questions that are asked by the nursing staff. If an individual is on psychotropic medications or they've engaged in suicidal behavior, like a suicide attempt, they would be, or they're on a suicide watch, they would be referred to mental health and seen typically that same day during Monday through Friday, or alternatively, the next business day. We have, and I'll say more about this if you like, we have 24-hour on-call psychiatry, and I actually participate in that 365 days a year. So when an inmate comes into a prison setting, we have the ability to continue their medications from county jail. We have the ability to put them on a suicide watch if needed. And say somebody were to come in from county jail and they were psychotic, they were paranoid, or they're, really ill, or they're suicidal, we could put them and refer them to crisis management. And I can say more about that. And we could put them on a suicide watch or observe them until they're moved by custody to that setting.
You mentioned crisis management. First of all, what does that mean? And what is the availability of the folks who actually handle crisis management?
Certainly. So crisis management it's a big term because any one of us, if we went to jail or prison, it would be very scary, it'd be a frightening experience, it'd be very stressful. So crisis management is a safety net where an individual is referred to a special unit that has crisis management beds. And it's a higher level of supervision. There's mental health staff physically on site there. And whether they're male or female, it depends where they go, but they can be referred, and it could just be a situational issue, like they're upset about being incarcerated, or let's say they had a family member that died from COVID, or they had some other stressor or conflict. Those are reasons why somebody might, or they're having a conflict with their cellmate, or they're not happy about being locked up. They could be referred to crisis management. And that goes for anyone in our system, even if they're day one, they're brand new, or alternatively, they've been here 5 or 10 or 15 or 20 years, they can be referred to crisis management at any time. We have different crisis managements for males and different ones for females are kept separate. But while at crisis management, they're kept safe, they're monitored, things that they could use to hurt themselves or hurt somebody else would be taken away. And then they undergo mental health evaluation and or psychiatric evaluation. And we have, and I'll say more about this if you like, we have 3 psychiatric prison units that are dedicated they're like a psychiatric hospital. They're like akin to a psychiatric state hospital. We have 3 of those in our system in the state of Texas. And if someone were in crisis management and they're not improving, or they're worsening, or they're really psychotic and ill, we could admit them to one of our diagnostic treatment tracks at one of those units for further evaluation and treatment.
Now, you mentioned the state hospitals and how you have 3 facilities where treatment or services that are oftentimes available in the state hospitals are available there in the prison system. Now, in the state hospitals, would you agree with me that those state hospitals can only be used in very specific situations for people out in the public?
I would agree with that, yes.
Okay, it's not easy to actually admit somebody into a state hospital, and they have to fall into a very specific category of person in order to be sent there, right?
I think that's fair. And I don't know if you want me to clarify or add more to that of my experiences in dealing with that or my knowledge on that.
Sure, yeah, go ahead.
Well, as everyone in the courtroom probably is aware that if somebody were found not to be competent to stand trial, they could be referred to the state hospital. And unfortunately, and this is not a slight on Texas, this is nationwide, other states are dealing with the same issue. There could be a backlog. There could be a wait of 3 months, 6 months, 9 months, up to a year for an individual in a county jail to be referred to the state hospital to be evaluated for competence to stand trial and then their competency restored. So that's the biggest challenge is right now there typically is a backlog or wait to get into the state hospital across the U.S. It's not just unique to Texas.
Okay, and so with the three facilities that you mentioned that are available in the prison system, is there ever a situation where somebody is turned away because of a shortage of beds or it's too full?
So I wouldn't say we turn people away. What I would say is we have 3 of these facilities and each of them are 550 beds, but our mental health population has grown in the state of Texas and we have not built, and when I say we, the state of Texas has not funded or built any additional inpatient psychiatric beds for prisoners in the prison system. Occasionally we'll have a delay of say a day or 2 or 3 days when somebody is on the launch pad, they're referred to inpatient, but the beds are not available. We can keep them safe and on a suicide watch, or alternatively, they can be watched and seen by mental health staff and be seen by psychiatry. And I can say more about that. They can be seen in person or via telemedicine. We have that statewide, and we have a statewide electronic medical record. So there's eyes and ears on people, even if there is a backlog at our 3 inpatient psychiatric facilities.
Okay. So there may be a day or 2 of a wait, but nothing like what we see in the state hospitals of maybe 3, 6, 9 months.
No, I would be in a lot of trouble. I'd probably be sued in federal court if that were happening.
Right. And to be clear, before we go any further, you and I haven't discussed anything about this particular case, right? You're not here to talk about Bryan Cahill or any of the situation or the case surrounding him. Is that right?
That's correct. I don't know anything about this gentleman. I don't know the facts of his case, what he's charged with. I don't know his mental health history. I think it would be a conflict because my job is to provide health care when people are incarcerated. I'm not testifying in a capacity as a forensic psychiatrist, which I do, in civil and criminal cases outside of the state of Texas. But no, I don't know anything about Mr. Cahill.
Okay. So going back to the mental health services available, once somebody comes into the mental health facility, let's say that they are in crisis management, they have to go to a psychiatric facility within the prison system, they get one of those beds, and they're there for a while. What is the goal of the prison system once they actually enter that facility, that psychiatric facility?
Certainly. So the goal, and if I could back up, are the referral to crisis management. The crisis management units for the males are actually at those inpatient prison units. And maybe if I clarify, there's 3 of them. There's one on the Texas Tech side is the Monford unit, and that's in Lubbock, Texas. Then the other 2 are within the UTMB sector. That's the Skyview unit, and that's in Rusk, Texas. And that's actually, I could throw a rock and hit Rusk State Hospital. That's how close that unit is to the Rusk State Hospital. And then lastly, and that's a Skyview unit. And then there's Jester 4, and that's in Sugar Land or Richmond, Southwest Houston. So that's where those units are. But the crisis management units are actually at those facilities. The only exception to that is our females. We have crisis management at Mountain View unit, which is in Gatesville, Texas. So that's the only difference is for females, it's a little bit different. But for males, the crisis management is at Jester 4, Skyview, and Monford. And I'm so sorry, I lost track of the question. I apologize.
No, that's okay. What is the goal once an inmate enters the psychiatric facility, gets one of those beds? Is the goal to keep them there forever, or what is the ultimate goal there?
Great question. So the goal is stabilization. Well, first of all, diagnosis, evaluation, and stabilization. And at the end of the day, we're all about least restrictive environment. So yes, we have some individuals, and I'm happy to discuss maybe one of them who's pretty high profile, and it's not a HIPAA violation because he was featured in Texas Monthly and other articles. But we have some individuals that stay at Jester 4 for years or Skyview for years. They just can't function in a general outpatient unit. But for the most part, we make a reasonable attempt to afford individuals the least restrictive environment. So they will have the opportunity, and many of them don't want to stay at Jester 4 or Skyview, and I can say more about the reasons why they wouldn't want to stay there long term. But we do everything within our power and ability to stabilize them and get them back to their unit of assignment. Or alternatively, if they can't function in outpatient in general population, they might need to be in a sheltered program or specialized program. And I can say more about those, like individuals with intellectual impairments, formerly known as mental retardation. We have 2 of those units, one for male and one for females. We have other units that we provide access to care for individuals that have special needs. So I'm happy to say more about that if needed. Okay,
so backing up, why wouldn't somebody want to stay in one of those psychiatric facilities, whether it be the Skyview or the Jester 4, long term?
Sure. So a couple of things. One, it might be a variety of reasons. Maybe their family is across the state and getting to that facility is a challenge, especially, after or during or after COVID. So visitation can be a challenge. They might particularly like a unit where they've been before and they've made friends or, with other inmates, or they like the staff there. But frankly, a lot of it has to do with privileges and work. And I'm not speaking as a custody expert, but I'll tell you that most prisoners, they're expected to work or have jobs. And there's everything from vocational stuff, like they can learn different crafts or trades. They can get their GED or go and get a high school diploma or college credits through the Wyndham School Department. We have a faith ministries program where individuals can become ministers and then minister to other inmates. So there's a tremendous amount of things. I don't know if y'all can see in my office here, but there's a pillow there of the Texas flag, and that was made by female prisoners at the garment factory, and they make flags just like the one behind Judge Smith, probably, They make flags, they make banners. So they also do Braille, like for individuals that are blind. They make things into Braille for individuals in the free world. There's programs for service dogs for the military that our inmates get to do. So there's so many different vocational, recreational, and activities and programs that I'm probably, again, hopefully I'm not disrespecting custody, because there are just so many additional things that they do to help rehabilitate and reentry our inmates. So those are the sort of things that inmates want to have access to, and more privileges and more freedom and more out of cell time in the outdoors, as opposed to being at Gesture 4 or Skyview for a long term.
So we're not saying that being in prison is a walk in the park, but there are some of those things available to them to make life as normal as possible while they're in the prison system. Is that right?
I would say that's absolutely fair. Probably the highest level of privilege would be to be a trustee. And those are individuals that can kind of walk around the campus. They clean things, or they garden, or they have privileges, and they're basically afforded a lot of flexibility, and they're pretty much out of their cell most of the day, and they have day jobs, like they go and work, in the fields, or they have jobs. There's different things, license plates, laundry, food services. I mean, there's just so many different things that they're afforded. So, and they're valuable trades. Like a lot of our inmates, when they release, they could go and work, in restaurants or the restaurant industry. So there's a lot of things outside of Gesture 4 and Skyview for individuals to partake of.
Okay. Now, backing up, we talked a little bit about the fact that there are mental health services available. Talk to me about the quality of the care that these inmates receive when it comes to their mental health needs.
Certainly. So I don't want to overpromise and say everything is perfect, everything's wonderful, but we are accredited nationally by the American Correctional Association. All of our facilities, there's 100 facilities across the state of Texas, TDCJ facilities. They're all accredited by the American Correctional Association. So in other words, our healthcare undergoes review by people from other states through the ACA, and they routinely come in and look at what we do and how we do it. They review records, they talk to inmates, they tour the facilities. And so all of our facilities are ACA accredited. We also have, as a result of the lawsuits and litigation, there's a total separate branch within TDCJ, Texas Department of Criminal Justice, that's called the Division of Health Services. And their medical director is Dr. Lynette Lithicum, and it's a mouthful, but they actually audit and monitor and do oversight of Texas Tech and UTMB, and they have all these access to care indicators. So they're constantly in our business looking to see, are we providing access to care? If inmates don't get what they want, they can file grievances. So there's a grievance process in place, and they respond to that. If family members or loved ones are concerned, they can call the hotline. They can call the patient liaison line, which is available, and say, hey, my loved one should be getting this, eval or treatment or medication or whatever. And then we will investigate, and we have to, we have a limitation on how much time we have to respond to that. So there's a variety of people watching what we're doing, and we have to be in compliance. And then there's a Correctional Managed Healthcare Committee, which is a state entity, and all those are appointees by the governor, and they also monitor what the Texas Tech and University of Texas Medical Branch, what we do to provide healthcare to prisoners. So there's a lot of, we're like the goldfish in the bowl. That's the easiest way I think of it. What we do is being watched and scrutinized. And then frankly, we get called to hearings at the Capitol in Austin, the House Criminal Justice Committee or the Senate, and we have to explain what we're doing and how we're doing it and the quality of care. And then lastly, we have our own internal, we have our own internal quality measures where we do Lean Six Sigma. We have key performance indicators where we monitor medical issues or dental or mental health or psychiatric issues, and that we have to meet a certain standard. So those are all things that we do both externally and internally.
And when it comes to staying up to date on the most recent research or medical care available to mental health patients. Do y'all keep up to date with that, or are you using antiquated treatments for mental health patients?
So I would say we definitely keep up to date. Our treatment is evidence-based, and what I mean by that is we're not using the latest medications that the drug companies, the pharmaceuticals are trying to pitch or roll out. We have a pharmacy and therapeutics committee that monitors every medication that's used for every disease state, and so we have algorithms, and it's similar to what's done in the state hospital and in county jails too. But everything we do is evidence-based, and it's based on national clinical practice guidelines. So like my job is to make sure we're in compliance with the American Psychiatric Association and what's their standard for treatment of schizophrenia or patients with bipolar disorder, or patients with depression. We have clinical pharmacists that's all they do is make sure that we're doing the right thing. And, you know, to be frank with everyone in this hearing, my license is on the line. I came to Texas, I'm fully licensed. Knock on wood, I've never had a disciplinary issue. And so at the end of the day, I'm committed to providing quality healthcare in the prison system. And I would say, and I'm under oath here, I would say we provide as good, if not better, healthcare than what would be available in many areas of the state of Texas, especially in rural, small counties and areas, and probably comparable to what's done in the state hospital. And we provide timely access to care. And I can have a patient seen the same day within an hour or two if needed by a board certified psychiatrist or psychiatric nurse practitioner or PA, and it's totally independent of insurance companies or managed care. We can provide access to care. We can have people seen the same day and referred to Jester Force, Skyview, or Montford within a timely period.
Okay, I want to fast forward now to when somebody is reaching the end of their time in prison. Are you a part of the parole process or aftercare when somebody gets out of prison?
I would say no, and qualify my response with some yes to that, in that we're the healthcare entity. So we provide healthcare from when they hit the door to when they leave, but we are involved with TCOME, and it's a mouthful. It's the Texas Correctional Office on Offenders with Medical or Mental Impairments. And so, like, let's say an inmate is on dialysis, that's the easiest, or they're on hepatitis C treatment and they're releasing, or they're on chemotherapy or certain medications that they need to continue. TCOME would get involved and they would help figure out, do they need to go to a nursing home? Do they need to go to a group home? Or if they have a mental illness, they arrange aftercare and follow up with a psychiatrist or mental health center, Social Security benefits, Medicaid, getting them a driver's license or proof of, license so they can apply for jobs or do whatever. So we assist TCOME, but TCOME, that's the entity in TDCJ, that's their job. Our job is to help alert if we know an individual has a serious mental illness and will need follow-up and treatment in the community. And worst case scenario, if we have an individual who's still psychotic or not doing well, and we get people sometimes that come in very short-term stays, let's say they have less than 2 years, they might come in and do a lot of their time in county jail and then show up and be with us like a month or two. And let's say they do K2 or Spice or some illicit drug and they become psychotic, or they just become psychotic because they have, serious mental illness. We can take steps to civilly commit them to a state hospital when they release from TDCJ. We don't just say, kick them out the door and say, have a nice life. We could civilly commit them to a state hospital if needed. We don't do a lot of those, maybe less than 50 a year. And then lastly, when we discharge patients, we don't discharge them with nothing. We provide them with at least 1 month supply of their medications. And again, TCOME would be responsible for helping arrange their aftercare and follow-up.
Okay. And you've given us a lot of information, but the big picture is that if anybody in this courtroom thinks that when somebody goes to prison, they're just locked in a cell without any treatment, that's not the case. Is that right?
I would say that's absolutely correct. And also, we would probably be getting sued in federal court and or state court if that were occurring.
Kathleen.
Good morning, Dr. Penn. My name's David Haynes. I'm representing the defendant in this case. I've got a few questions for you.
Good morning.
Good morning, sir. So UT, I'm guessing that means the University of Texas. What does MB mean?
And I apologize for not, so UTMB, University of Texas Medical Branch, that's a medical school. It's in Galveston, Texas. And I'm very proud of it because that's where I went to medical school, but it's the oldest medical school west of the Mississippi. And it's a medical school, but they also graduate nursing students and, you know, other students, allied health, occupational therapists and physical therapists and such. But under that university, that's how myself and the other staff that work with me, we're all part of the University of Texas Medical Branch, MB,
Right.
like medical branch.
All right, and so that university has contracted with the state of Texas, the Department of Criminal Justice, to provide the medical services to 80% of the population of the what we used to call the institutional division. Is that a fair understanding?
So not to quibble, but I think it was actually said in statute. In other words, the state was ordered to do this. So I think you're correct that there is a contract, there's a master contract, but as I understand it by statute, Texas Department of Criminal Justice, to get out from under their federal lawsuit they were in the 1970s and 80s, they designated that Texas Tech and UTMB would be the healthcare providers. I think recently, probably in the last 2 or 3 legislative sessions, there's been a push to maybe look at privatization, and some private companies have come in and made presentations. But as I understand it, it's by state law or statute that UTMB and Texas Tech are the healthcare providers for the state prison system.
So the state can't just switch to another provider. They would have to pass a law in both houses of the legislature and get it signed by the governor, right?
That's my understanding. Yes, sir.
And then, of course, whether they could do that or not, that's under the oversight of the federal court.
No, well, no, sir. The federal court is non-existent in Texas right now. I mean, that case was resolved. The Ruiz, R-U-I-Z, that was the Ruiz litigation that I spoke of in the 1970s and 80s. That was, Texas is no longer under that lawsuit or litigation.
All right. So it's up to it. They couldn't just decide, oh, gee, we want somebody else to do this. They'd have to pass a law in Austin and get the governor to sign it.
Yes, sir. And if I may, when I say we, by being a 340B, that's 340B like boy entity, which is kind of like Medicaid, we're able to save the state about $110 million a year on hepatitis medications, HIV medications, and psychotropic medications. So we save the taxpayer close to $100 million a year because we get medications below Medicaid rate. So if a private entity were to want to come into Texas and do what we do, they would have to make a profit of $100+ million a year just to break even. So we save the state a lot of money because we're a 340B entity that gets that discounted rate on medications.
All right. So when a new prisoner comes into the institutional division, it used to be they all went in through one diagnostic unit, but I'm getting from your testimony that there's more than one intake point at this point. Is that correct?
Yes, sir. That's fair. And again, don't hold me to this. I think there's like 20 intake units across the state. I know things have changed because of COVID. The number of inmates coming in from county jail has reduced, but it's gradually ramping back up. But I would agree that it used to be one diagnostic and now it's pretty much like 20. There's like 20 intake facilities where somebody might come in through. That's fair.
All right. And when they come into one of the intake units, they are screened by prison staff who work for the institutional division and by UTMB staff.
That's fair. Yes.
I mean, you have some staff that work for your organization who are at each of the 20 intake units.
Yes, that's fair.
All right. So how many total prisoners are there in the entire institutional division?
So I can't answer off the top of my head. I can tell you before COVID, we were the largest state prison system in the country, larger than California. We were at about 152,000. I think the number went down during COVID to maybe 130,000, but don't quote me on that. I don't know, as we sit here today, I don't know the exact number where we're at today. That would be a question you could ask TDCJ, and they have that sort of stuff available, readily available.
All right, so of those, how many are mentally ill persons?
So I wouldn't be able to comment on the exact number. I can tell you that, well, first of all, how are you defining mentally ill? Like what would be your definition for mentally ill?
Well, I would defer to you because you're the psychiatrist. So, whatever of 152,000 about people who are prisoners in our institutional division, how many of them are mentally ill in a way that a psychiatrist like you would recognize and say, oh, that person's mentally ill?
So I can't answer your question. Maybe if you could ask it a different way, I'd be happy to try to answer it. But I'm not understanding your question. I apologize.
All right. Well, so how many of the 152,000 are receiving services for mental illness from the UTMB branch?
Yes. So we publish and we have caseload reports, and I apologize, I don't have that in front of me. I wasn't aware I was going to be asked these questions, but I can tell you that we monitor, and I can only speak for the UTMB side. I can't speak for Texas Tech. But I can tell you that we probably have about 20,000 inmates on the mental health caseload. And then probably of those, probably 90% of those are on psychotropic medications. But what's important, and when you asked about mental illness, I mean, some of those could just be for anxiety or for depression or post-traumatic stress disorder, PTSD, or sleep problems, or other things in addition to serious mental illness. So when I say, and I can define what I mean by serious mental illness, but a lot of those are very common things that you would see in the community, and they're not somebody I would say is gravely disabled or seriously mentally ill.
Right. Well, yeah, I get that. But I mean, the purpose of this line of questioning is you've got 3 psychiatric units, each with 550 beds. So that means the people who are in the psychiatric units are never going to be much more than about 1,600 people, right?
Well, I think that's fair, but I think one thing that wasn't able to answer my question was, we have a continuum of care where we have psychiatrists, psychiatric nurse practitioners, physician assistants, and then we have master's and doctoral level mental health staff that are providing outpatient care to inmates that are in outpatient units. So our model is not just of keeping people in the state hospital or keeping them in the inpatient unit. Our model is to provide health care to them and ideally help them reach optimal functioning in outpatient units. So you said 3 of the units are inpatient. That's correct. The other 97 are outpatient units, and we want our patients or individuals, the inmates, to function and do their best and be at outpatient units. So the inpatient is kind of like our ICU, if you will. We stabilize them, we get them better, and some of them may need to stay in the hospital for longer periods of time. But most of our inmates, we want them to go home and be in an outpatient setting at a prison unit.
Right. So, I mean, that's the point of the questioning. Most of the prisoners in the institutional division who are receiving mental health services are being managed on the regular units. Fair?
That's fair, yes.
And indeed, that's the preference, because it's more economical to manage them on the units than to have them in the hospital units, right?
So I would not agree with the economical piece, because we don't make a profit. We do this contract at cost. We're not like a for-profit private vendor where we make money on how many people we have in the hospital. It makes no difference to me or to my colleagues. You know, we don't get paid for how many patients we have in the hospital versus not. So I would not agree with your thing about economically. It's more of a civil rights. It's about least restrictive and providing the most appropriate health care to individuals in the least restrictive setting.
Well, it makes a difference to the legislature, right? It's the legislature that pays the cost of the treatment that you provide.
With all due respect, sir, I would say no. I would say taxpayers are paying. I mean, the legislature appropriates or makes mandates, but you and me as taxpayers, we're the ones funding all the healthcare and the day-to-day operations of prison facilities.
Well, yes, ultimately, it's our taxes that are providing the funds that pay the expenses, but you and I don't have anything directly to do with that. The legislature decides where the tax money the state collects goes, right?
That's fair.
And they have a lot of things they have to pay for that are not the UTMB system, right?
Absolutely. I would say every prison unit is kind of like a little city. It's like every prison is, you have to have heat and air conditioning and the physical plant and, the roofs leak and you have to fix that. And you have to feed the inmates and clothe them and provide, showers and toileting and all. So absolutely. It's like every prison is almost like its own little cruise ship, if you will.
And the point is there are unlimited desires, but limited resources. The economic problem we all face, right?
I'm not sure if I can answer your question. Are you speaking about healthcare or are you speaking about physical plant? I'm not understanding your question.
Well, I'm speaking about the legislature's efforts to meet the expenses of the state of Texas in the widest possible sense. They have to economize where they can and spend where they must. Is that fair or unfair?
Well, again, I don't consider myself to be an expert in, public government or finance or fiscal. If you're talking about healthcare, I'd be happy to answer anything about healthcare issues and in particular mental health care. If you want to ask me about what my opinion is or how to answer about what.
All right. Well, let's move on. Let's move on to something else. We're almost done here. All right. So you indicated that each prison unit was kind of like its own little city or cruise ship, but it's not a city or a cruise ship. It's a prison, right?
That's fair. And when I was using the cruise ship analogy, that's something that I use with my neighbors and relatives and friends to explain about COVID, because, I don't think people understand, what we've been through as a state and as a country in the prison system and in jails dealing with COVID, and what, the Herculean tasks and efforts that our staff have done to minimize morbidity, death, and mortality, sickness in our inmates from COVID. I think our staff and our correctional officers have done a fantastic job. So I apologize. That's why I use the analogy of a cruise ship.
All right. So, it's a prison and people are there because they've committed crimes and they're being sent there to be punished for them. Fair?
So I don't know if I would use the word punish. I'm not an attorney or criminal jurisprudence person, but I think, as I understand it, the mission of TDCJ is rehabilitation and reentry. So I'm not sure if I would agree with the punish part. Obviously it's not a fun place to be, and I wouldn't want to be in prison myself, but I view it as it's an opportunity. And many of our individuals have mental illness. Many of our individuals have drug and alcohol issues. Many of them have both. And so our job is to provide treatment, evaluation, diagnosis, and treatment to get them better to where when they leave and go back into the community, they can be more productive and upstanding citizens and hopefully do better.
All right. Thank you, sir. No further questions.
Dr. Penn, thank you. No further questions from the state.
Thank you, Dr. Penn.
Thank you.
You can go ahead and end the call.
Thank you very much.
Members of the jury, At this time, all of the evidence is before you. All that remains is for you to hear the charge of the court, which contains the law that must govern your deliberations, and also the closing arguments from each side. I have prepared a draft charge for each indictment. There has to be a separate charge for each indictment. And I have to give the attorneys an opportunity to confer with the court on any suggestions they might have for changes. I think for the most part that's been accomplished. I think at this point, while we're finalizing the charges, it's probably most efficient for me to just let you go to lunch. When we bring you back into the courtroom after lunch, I'm required to read the charges to you out loud. That is probably going to be a somewhat lengthy period of time. Hopefully I can avoid reading the same portions second time or seventh time. After I read the charges to you, you'll hear the closing arguments from the attorneys, and then the cases will be submitted to you for your deliberations. Why don't you all be back in the jury room ready to go forward at 1 o'clock? Thank you.
All right.
All right, you all can be seated. Now we have juror number 1, Mr. McGowan, who has a flight tonight. Now, we could just keep him on once they begin deliberations, separate the alternate, and see if they reach a verdict before it's 0 hour for this juror to make his trip. But if we wait and do that, if they haven't reached a verdict by the time he has to leave, if I seat the alternate at that point, the jury will have to begin the deliberation process from the beginning, since the alternate wouldn't have taken part in any of that. So we can do that. I can declare him disabled now. I can declare him disabled and seat the alternate after the cases have been submitted to the jury, so after closing arguments. So I just want to see if either side has any thoughts or preferences or suggestions with respect to how we're going to do this moving forward. I mean, in my opinion, I'm not sure that I can find him disabled until it's 0 hour or he's going to miss his flight. And even then, I'm probably only going to be able to declare him disabled by agreement, in my opinion. But if by agreement we want to do that sooner, in order to accommodate any planning that he needs before he has to go to the airport, then I'm willing to do that as well. So do you all have any preferences as to how we treat Mr. McGowan?
Would it be possible have the court inquire of the jury just confirm that what we're thinking still is, like, just to confirm, are you still planning on leaving tonight? And is that going to cause you discomfort as far as being around still? I would be fine if we would agree to allow the court to pull the juror with regards to those questions, and as of right now, I feel like I don't know enough about the situation to know whether or not to agree
Do you want me to bring him in here and ask him questions on the record, or do you want me to just go back there and talk to him?
Contemplating sending him out at what? I'm not inclined to question him or to accuse him. I think we've got enough time to get the deliberation.
Well, I'm gonna start reading the charges at 1, but along with closing arguments, they may not get the case till 3. But my understanding is that his flight is at 11, so that does give us some time if he's already, for the most part, situated and packed and ready to go. So,
Well, if the court wants to bring him in and ask him about that,
all right.
about his plan and all that.
Okay, go ahead. Please be seated. Mr. McGowan, just wanted to get with you regarding your planned trip. I believe back last week during jury selection, you let us know that you had a trip, a flight leaving tonight. So I just wanted to check in with you about that. My understanding is that your flight leaves tonight at about 10:30. And is it out of Dallas? Out of DFW. Is it a business trip or a vacation? And how much lead time do you feel like you need to be out of here and done with this in order to make sure that you're on that flight with everything that you need to have with you?
If I could leave it late at 9 o'clock, maybe 8:45, around there.
Okay. Okay. And oh, good. That's great. And also, you don't feel like that trip is creating such a distraction as far as being able to carefully attend to the evidence and the testimony and to the deliberations. You think that you would be able to focus on that and not be too worried or stressed out about your trip? Okay. You should be getting the case, I imagine, between 2 and 3 o'clock. So that potentially gives the jury 5 to 6 hours to deliberate. Hopefully you all can reach a verdict on all 7 cases by then. If you can't, and we reach that point where, you have to, if you're going to make it on that flight, you're going to have to leave. I may have to declare you disabled and seat the alternate. But we'll cross that bridge if we get to it. But I just wanted to make sure that we had the information that we needed, and also that you knew where we were coming from as far as what we're looking at as far as time frame. So thank you very much, sir. Does either side have any additional questions for Mr. McGowan?
No, sir.
All right. Thank you very much, sir.
All right.
All right, please be seated. Do you all want to have the formal charge conference now, or do you want to do it after lunch? Okay, all right. We're outside the presence of the jury. All parties are present. Has the state had an opportunity to review the court's proposed charge in all 7 cases? Does the state have any objections or requested inclusions on any of the charges? Mr. Haynes, has the defense had an opportunity to review the court's proposed charges in all 7 cases?
Yes, sir.
And, sir, does the defense have any objections or requests for inclusion?
We do not.
All right, very well. We'll see y'all at 1 o'clock.